Morning everyone, my name is Kevin Infante. Thank you for joining me this morning. Today I want to share with you a brief lecture about a medication that we frequently give here in our post-transplant unit. The medication is called Tacrolimus. This medication, we use this for immunosuppressive maintenance for post-transplant patients. The goal of this presentation is to present a brief overview of the pharmacology indications, significant side effects, adverse effects, and toxicity signs and symptoms associated with tacrolimus use. At the conclusion of this lecture, there will be a short 5-item quiz taken using the SurveyMonkey platform and a brief survey or evaluation of the presentation. This lecture is designed for the new registered nurse working in our clinical setting, which is the multi-organ transplant step-down unit. It is also a good refresher course for the experienced nurse. The objectives today would be to discuss the basic pharmacokinetics and pharmacodynamics of tacrolimus, list the indicated use of the drug tacrolimus focusing on the post-transplant population group, and list the side effects, adverse effects, and toxicity signs and symptoms of tacrolimus use. This is the content breakdown of what we'll be discussing over this short lecture. Now let's go over to solid organ transplantation overview. We cannot discuss solid organ transplantation without mentioning UNOS, or the United Network for Organ Sharing. This is a non-profit organization and is the nation's largest organ transplant system under contract with the federal government. It has many different roles, one of which is managing the national transplant list, matching donors to recipients, maintaining the U.S. organ transplant database, providing 24/7 support to the transplant community, and ensuring that organ allocation policies are followed. That in the United States, back in 2019, the total number of transplants performed was 39,718 in total. This is a 8.7% increase from the 2018 number. There has also been a 10.7% increase in deceased donors and a 38% increase in organ donation from deceased donors since 2014. The number of living donors in 2019 numbered 7,397, which is an all-time high record. Let's watch this brief video from the Barnes and Jewish Hospital regarding tacrolimus. This has good patient teaching points that you can share at the bedside.
Hello, I'm Dr. Keith Fuster.
Tacrolimus is classified under the calcineurin inhibitor immunosuppressive agent category. Brand names include Astrograph, Envarsus, Prograph, Hecoria, and other names for tacrolimus is FK506. Indications for tacrolimus use include rejection prophylaxis and acute rejection therapy for liver, lung, heart, kidney, pancreas, and small bowel and bone marrow transplant recipients. It is also used for treatment of refractory or chronic graft rejection. The drug was first isolated from the bacteria Streptomyces trucobensis in 1984. It reduced rejection episodes and has better tolerability versus cyclosporin A, which is another calcineurin inhibitor. Adverse effects of tacrolimus include nephrotoxicity, hypertension, diabetes, neurotoxicity, hyperkalemia, hypomagnesemia, hirsutism, gingival hypertrophy, and hyperplasia. Tacrolimus is more associated with neurotoxicity and diabetes, and the other calcineurin inhibitor, cyclosporin, causes more of the cosmetic side effects, which include hirsutism and gingival hyperplasia. Other adverse reactions of tacrolimus include infection, nephrotoxicity, hepatotoxicity, electrolyte abnormalities, like I said earlier, hypertension, hyperglycemia, as insulin-dependent diabetes mellitus, cancer, post-transplant lymphoproliferative disease. Neurologic adverse effects include seizures, convulsions, confusions, mood changes, anywhere from migraines to insomnia, encephalopathy, and neuropathy. The mechanism of action for tacrolimus is the inhibition of the first phase of T cell activation, leading to decreased number of proliferating T cells that attack the transplanted organ. The mean half-life of the drug is about 12 hours. Normally, calcineurin cleaves a phosphate group off of the nuclear factor of activated T cells. This transcription factor then enters the nucleus and initiates the production of interleukin-2, as well as a host of other chemokines that lead to T cell replication. Prograf acts by binding through immunophilins known as FK binding proteins, or FKBP, shown here in this image. This complex of Prograf and FKBP interferes with the activity of calcineurin. With the dephosphorylation interfered, T cell proliferation is halted. Prograf also has some inhibitory B cell production actions, but to a lesser extent. Monitoring serum levels of Prograf is important, and the typical traditional therapeutic trough concentration is between 5 to 20 nanograms per milliliter, depending on the type of transplanted organ, the transplant team's goal, and the patient's tolerance for the serum concentration of the drug. Like it says here, therapeutic concentration must be individualized depending on the type of transplant, time of transplant, and concurrent immunosuppressants. I've listed here 3 notable research that you might find interesting. First is the one done by Kim and colleagues, showing that the generic form of tacrolimus has shown comparable outcomes compared to the brand name tacrolimus in liver transplant recipients. As we all know, generic versus brand name medications have quite a bit of price variation. Another one by Yüksel and colleague made recommendations for tacrolimus use during pregnancy in kidney transplant recipient mothers. And lastly, tacrolimus has shown some short-term clinical response in patients with inflammatory bowel disease. I also want to share with you some patient resources that you can share with your patients. First is the American Society of Transplantation, then the American Transplant Foundation. Also, the Prograf website is very helpful, and of course the United Network for Organ Sharing website is a great resource. Questions. Now you may ask, your patients may ask this, why do I take Prograf 9 a.m. and 9 p.m. and here at the hospital you give it to me 6 a.m.? Now the answer is it has something to do with our trough level collection. So traditionally our trough levels are collected early in the morning before the morning dose. That's why there is a couple of hour adjustment on the dosing of tacrolimus here in the inpatient setting. So right before you give the morning dose or the 6 a.m. dose of Prograf, you should be drawing a trough level to accurately measure the serum trough level concentrations in the patient's blood. You should tell your patients to not worry. At 2-3 hours of change in the dosage time will not significantly affect their regimen. Here are my references for this presentation, and I encourage everyone to take this evaluation and quiz of the presentation. If you have a QR reader on your phone, you can go ahead and do that now. You can access it through this image or through this link, SurveyMonkey link, for that quiz. Thank you for joining me today.